Hello, everyone. Thank you for joining us for this installment of the Root Cause Coalition's 2018 How-To webinar series. Before we get started, I wanted to run through a few features of our webinar today. All of our attendees will be in listen-only mode for the duration of the webinar. At the end of the webinar, our panelists will be answering audience questions. If you have a question during the webinar, please type your question into the question pane on the webinar control panel, usually located at the right side of your screen. This webinar is being recorded and will be available for download on the Root Cause Coalition website later this week. Thank you all again for attending this webinar, and at this time, I'm going to turn it over to our presenters.
Hello, thank you for coming to our webinar today. We're going to go ahead and start by introducing ourselves. So my name is Kelly Schuring. I'm a fourth year at Vanderbilt University School of Medicine, and I am the Student Director of Social Work for Shade Tree Clinic, our student-run free clinic.
Hello, everyone. I'm Michelle. I'm a first-year medical student here at Vanderbilt, and I'm one of the staff social workers who helps oversee the transitions department.
Hi, my name is Thomas. I am also a first-year medical student here at Vanderbilt, and along with Michelle, I also work as a staff social worker and help oversee the transitions department.
Hello, my name is Shannon Jordan. I'm a medical social worker at Vanderbilt Children's Hospital and also at the Shade Tree Clinic with medical students.
Perfect. I am having some trouble going to the next slide.
One minute. It looks like we are
Okay.
a little bit of a technical difficulty. Sorry, guys.
Let me know if there's anything I can be doing to help.
Kelly, if you could pull up your presentation on your computer, I can try and give you access from your computer. So it's sharing your screen.
Let me go to the presentation mode, sorry. Okay, so it should now be up on my computer.
Bearing with us, thank you. Did you say your the PowerPoint is up on your screen?
Yes, it is up on my screen.
I'm gonna change it to your screen now, and we should be up and running.
Okay, perfect. Great. So we will go ahead and get started. So to start with, we just wanted to remind you all of what the learning objectives for today's session are. I won't go through them in detail, but really our main goal is to describe our process for transitioning patients from Shade Tree Clinic to outside community providers and give you some tips and tricks about how you may be able to implement this yourself. So in terms of our presentation, we're going to start by giving you an overview of the clinic itself. Then we're going to go into how we screen for patients that may have insurance. And we're going to go through the transitions process, including how we provide follow-up for those patients after they've seen new providers. And then finally, we're going to end by discussing barriers to transition, as well as lessons learned and some tips that we think may be applicable more widely. So to start with, what is Shade Tree Clinic? So Shade Tree Clinic is a student-run free health clinic sponsored by Vanderbilt University School of Medicine. It was founded in 2005, and we've been providing care on Tuesday evenings and Saturdays in our current location in East Nashville since 2011. We provide comprehensive care to our patients completely free of charge. Our care model includes management of both acute and chronic illnesses, providing specialty care and procedures, free prescription medications, identifying and addressing social needs through the social work department, working with patient health educators to improve health literacy, as well as screening for legal needs and so much more. Our annual budget is roughly $170,000, and we receive financial support through the university, the medical center, community grants, and donors. The clinic is completely run by volunteers. To give you a sense of how many people are involved, in 2016 to 2017, we had over 400 volunteers, including more than 40 faculty members, who dedicated more than 6,000 hours of their time towards serving our patients. During that year, we were able to treat 6 patients for hepatitis C, vaccinate more than 70% of our elderly patients, and screen over 300 patients with an annual assessment through our social work department. So who do we serve? Shade Tree Clinic serves more than 320 of Nashville's most vulnerable community members. This includes patients who are uninsured or underinsured, patients who may be undocumented, as well as those who may be experiencing homelessness. Just under half of our patients are Spanish-speaking, and most are minorities. Our patients have a lot of medical and social complexity on average, having 7 problems on their problems list, and take an average of 7 medications. So as we mentioned, Shade Tree Clinic is completely student-run. In order to ensure patients have access to holistic care, our clinic is divided into multiple departments. Students take the lead in each of these, from checking a patient in to seeing them during a clinical encounter, drawing labs, dispensing medications, providing additional education, and even fundraising to help keep the doors open. We all work within the social work department, which is led by Shannon Jordan, our staff social worker. Within the social work department, there are also sub-departments in order to ensure that our patients have access to holistic care. The social work department is led by Shannon Jordan, our licensed clinical social worker, a student director of social work, a role which I'm currently filling, as well as 8 medical and nursing students who serve as staff social workers. The department is further divided into sub-departments, which allows staff members to gain expertise over some of the most common social determinants of health faced by our patients. 1 to 2 people oversee each of these sub-departments, which allows them to gain expertise in managing the follow-up of these needs amongst our patients. We also work with a variety of partners in order to support this work. This includes a medical legal partnership based on partnerships with the Vanderbilt Law School, Legal Aid Society, and as well as a local dental clinic, several mental health clinics, and a partnership with the midwifery program of the nursing school to support an early pregnancy program to help link women with insurance and obstetric care. I'll now turn it over to Thomas, who will talk a little bit more about our transitions process.
Great transition, Kelly. Tough crowd. Thank you, Kelly. As she mentioned, or as we mentioned before, I'm a first-year medical student, and I'll be going over a little bit on how we screen patients for eligibility for transitions. So first off, we keep mentioning the word transition, and I just want to make sure that we are all on the same page. To start broadly, our transitions clinic encompasses the process of facilitating the transfer of primary care services from Shade Tree Clinic 2 traditional community clinics for insured and eligible patients. In other words, if our patients are eligible for insurance, we want to make sure they get it. And once they have that insurance, we want to make sure they can use it. So as a result, we open more space in our clinic for uninsured and underinsured patients who have nowhere else to turn. So this department is vital for the health of Shade Tree Clinic and for its overall social mission for 2 different reasons. First, it helps us serve more patients in need of care. The pool of Nashville residents without access to health care is ever expanding, and unfortunately, our capacity is limited. So to continue opening our doors to new patients, we have to transition people to outside clinics if and when they have access to it. And secondly, this department addresses our mission of improving population health by inspiring our patients to take ownership of their own health care. Part of our screening process includes identifying and addressing barriers to care, and then working with our patients so that they can become increasingly independent. So here is a brief overview of what our transitions process looks like. First, we screen on whether our patients are eligible for insurance. If they are, we help them get access to that insurance and help them get subsidies if they're eligible for that as well. Next, we screen them for our transition meeting, in which we have several medical directors and student directors who will sit with us as the transition specialists and discuss what barriers there are for our patients and where the best fits are for them to transition. That way we can ensure that we are only transitioning people to good places where they are going to succeed. Next, we'll help identify the provider. We'll help facilitate the transition itself. And then we'll follow up with them after about 3 months to see how they're doing and to see if there's anything we can help continue to support them to ensure they have a successful transition. So first, we're going to talk about how we screen people for eligibility for insurance. We use several methods. First is using chart reviews. We have an electronic medical record system that we use that shows people's health insurance status. We ask the clinical teams to check that and to notify us in social work if people do in fact have insurance. Secondly, we have annual needs assessments that we do within the social work department, one of which is checking for whether people are eligible for insurance. Next, we also have patient reports on whether they say they have insurance. Oftentimes, our patients will come in and not be sure what they've received in the mail, but say that they have received something from TennCare, which is Tennessee's Medicaid, or from Medicare, and we'll help work with them so that they can understand it and get the most out of their insurance. And next, we'll also check for people who are 65 or close to becoming 65. So this goes into a little bit more depth. Again, our main areas are Medicare, where our patients, once they turn 65, we work with them to ensure they have adequate coverage. We also have patients who have SSDI disability. Many of our patients do have this, and so we have to make sure that they are aware that they are eligible for Medicare after 2 years. We also have many patients on TennCare, which is Tennessee's Medicaid program. Frequently, these patients will be those who are pregnant or those who have young dependent children, and they will tend to get TennCare through our early pregnancy program that we have a partnership with the nursing school at Vanderbilt to help run. Additionally, patients who have SSI disability insurance, which will help them, which makes them eligible for Medicaid. We also have some patients who are employed and have access to care through the private insurance market. But with that, we often make sure that our patients are adequately insured before we automatically transition them out. Oftentimes, cost is a barrier for many of our patients, so we also screen them for subsidies. These might include things like Medicaid supplements, the qualified Medicare benefits, specified Medicare beneficiaries, things like that. And in Tennessee, we refer patients to speak with the Tennessee's State Health Insurance Assistance Program, and this will help them navigate all of those documents and help them apply for those subsidies. In order to do this, we have a lot of very valuable partnerships that we work with. One of which is a health navigator with the Family and Children's Services, and she will often help with some of our early pregnancy patients. We also have, as mentioned before, the SHIP program, which helps people navigate subsidies for their health insurance. And we also have the Legal Aid Society, which will help with processing disability applications. These have been very valuable for us through the years. Next, after we have helped them get insurance and we've identified them as potential transition candidates, we will work them up before our transition meeting with the rest of the clinic leaders. One of the first things we do is we work on assessing fit for transition. This includes making sure they have adequate insurance coverage, as well as social and environmental factors that will help them be successful. We don't want to just transition people out of the clinic if they are not going to be successful and if it's going to harm their health care. So we screen them for different social determinants of health, which include things like social support, adequate transportation, medical literacy, and other language barriers. And so when we are transitioning them, we speak with them as frankly as we can about what those barriers to transitions might be, and we try to assess how we can help them address it to help improve their self-efficacy and make sure that they are going to have a successful transition. Next, once we have identified them as potential fits, we will approach the patients and speak with them about the idea of transitioning outside of Shade Tree. We try to do this as early as possible so that they're aware of what's coming and we don't surprise them with anything. Oftentimes, our patients are resistant to the idea of transitioning, but we always emphasize the different benefits of increased access, as well as their ability to help others access the care that they relied upon. One of the most tried and true lines that we'll use to speak with our patients is just reminding them that they didn't have anywhere to turn when they came in, and emphasizing that now that they have insurance, they can open up space for somebody else who also doesn't have anywhere to turn. And with this resistance transition, we always emphasize that they can come back and speak to us at the social work department so that we can continue to support them in areas outside the medical clinic. And our final step in preparing for this transition meeting is we will actually prepare transition forms, which is a way to organize all of the information that we might need to discuss these patients and ensure that they are going to have a successful and safe transition where they will succeed. And this includes things like medical appropriateness, where we list their problem list, medication regimen, where we will check whether they will continue to have access to the same medications, and whether there are ways that we can work around potential gaps in their medications or access to specialists. We also discuss their social factors, things like family structure, living structure, access to food, access to transportation, things like that, so that we can present as clear and accurate a picture as possible when discussing with the rest of our team. And with that, I will pass it off to Michelle to talk about what actually happens in these transition meetings.
Thank you so much, Thomas. So as Thomas just outlined, once we've laid the foundation and groundwork, we then schedule a transition meeting to review and examine each individual patient case. And so because this can be kind of a tricky process to go through, I'm going to do my best to kind of walk us through this as clearly as possible. So who's involved in these meetings? The meeting is typically organized and run by the social work transition specialist, Thomas and myself. And our aim for this meeting is to include the Shade Tree staff members and volunteers who are most closely and directly involved in the patient's care. That way we are able to paint the most complete picture of any advantages or barriers that might impact our efforts to relocate their primary care home. So this includes our medical directors, as well as our licensed social worker, Shannon Jordan, who's here with us today, our student executive directors, and our director of social work, Kelly, who you heard from earlier. So because Shannon and our core medical directors have known and cared for these patients for years, we feel that this is a really useful way to understand what medical and social factors might make them more or less successful in a new healthcare setting. And also, if the patient we are discussing is heavily reliant on their patient health educator, or PHE as I might refer to it later, or a pharmacy assistance program coordinator, we encourage these individuals to join the discussion as well, as they have a unique relationship with the patient, and that often offers insights that can impact our later decisions. So as mentioned, part of the preparatory work that Thomas and I do before each meeting is to write up concise outlines of each patient's medical and social history. This helps provide structure and organization to the discussion as we kind of walk everyone through each case step by step. So we typically start by reviewing the patient's medical diagnoses, as these can inform our patient's next step, or these can inform our next steps for the patient, and give us a sense of whether or not they're going to be a good fit to transition from a medical perspective. Their problem list can help, guide us in identifying the most appropriate primary care provider, or conversely, it can push us to consider them ineligible for transitioning. So for instance, we really try to avoid uprooting the primary care of patients who, carry an active cancer diagnosis, as we would really want to ensure that they continue receiving the care and social support that they require during such a difficult time. In addition, we discussed how heavily a patient utilizes specialty services in our clinic, which includes things like food assistance and dental care through our social work department, and again, how reliant they are on their PHE or that patient health educator or any other staff members for things like reminders to attend appointments or just for general social support. So before transitioning someone who is really reliant on these services, we have a deep discussion in terms of our confidence that they would be able to access something similar through their insurance. So next, we'll review their medication list. Because we provide medications free of charge to patients, as Kelly mentioned before, we feel that it's really important for us to ensure that medication access and compliance won't be an insurmountable issue once they're seeing another provider. So thus, we typically transition their medications to an outside pharmacy, utilizing their insurance even before we've scheduled an appointment with a new provider, and once that formal transition process is complete, so that we, A, improve the patient's comfort and confidence in their ability to navigate this component of their care, and B, so that we may identify any unexpected issues like increased cost or anything like that, while they're still able to receive medications through our pharmacy at no cost. So in addition, because medication coverage varies depending on the patient's insurance policy, we'll discuss any possible substitutions that might make their regimen more affordable without compromising their care in any way. So finally, and perhaps most relevant to this discussion, we review the patient's social factors that may impact the success of their transition. So this includes discussing things like their known social barriers, their support system, any concerns regarding access or lack of access to transportation, language barriers, and as mentioned before, any ongoing social work needs related to issues like dental care or vision assessments or food commodities. So this is where I think we really thrive as a program that will train informed future physicians, as I think this highlights and emphasizes the importance of not only acknowledging a patient's social environment, but using that information to personalize their care plan from a medical standpoint. So while we don't want to imply that, our resources or programs are superior, we do want to, in this process, ensure that patients are comfortable in their new clinic, so that fosters a trusting and reliable relationship between the patient and their new provider. So kind of considering all of those factors together, the meeting attendees will then make a decision on the next step. And for most patients, we move forward with transitioning their care. However, for a select few, we may realize that based on the group's discussion and input, that a patient may not be ready to transition. So we may temporarily or potentially permanently table that process for the patient and return to their case at a later date as needed. Okay, so now moving to identifying the provider. So for those who are transitioning, that's our next step in the process. And while sometimes this task is really straightforward, kind of the ease, or what we found is the ease at which we're able to find a new provider largely depends on the type of insurance a patient has. So in Nashville, Tennessee, which is where we're located, it is much easier for us to find primary care providers for those who have Medicare, particularly as this is accepted by Vanderbilt outpatient clinics, which is kind of where our students, most of our students go to school and most of our physicians work. However, for Medicaid patients, this often presents a more difficult path in finding a provider who meets the preferences of both our medical directors as well as the patient. So what typically happens is our medical directors will make the recommendation based on the patient preference, their relationship with the patient, and then their connections with providers in the area or close to where the patient lives. So again, we really heavily consider things like transportation, language, and any cultural preferences that the patient might have when we are determining what clinic will be best. So I know that was a lot of lead up, but we're finally to the transition stage. So to facilitate the smoothest transition we can, Thomas and I aim to really establish clear communication between all involved parties in this step. So first, we document the plan in the medical chart so that any provider or specialist or student who's involved in the patient's care is updated on what direction we're moving and what decision was made. And second, we discuss the plan with the patient and confirm, that it aligns with their goals and expectations. Also, this is kind of the time that we strongly emphasize the importance of self-advocacy when starting fresh in a new primary care home. And we emphasize the importance of their role in their own care as well as their responsibility in their care. So this comes with a little bit of health coaching. One step in the conversation is encouraging the patient to call and schedule that first appointment by themselves. That way we kind of encourage consistency in attending and scheduling appointments, as well as help their understanding and comfort with the new system. And for those who might need transportation services, we'll use this time to also assist them in making sure that they are scheduled for a ride service to get them to their first appointment. So finally, we'll send a letter to the new provider, which we feel kind of serves to informally introduce them or this provider to the patient. And we use this letter to accomplish kind of two major tasks. So first, this shares how Shade Tree or our clinic has been involved with the patient's care. And second, we use it to outline, the patient's care, including their diagnoses, our past and most recent management of those medical conditions, and then any pertinent social history that we want to make sure that they're aware of. So we really place a lot of value in this step as it promotes an open line of communication between us and their new provider, which we feel has been really instrumental in assuring a smooth and successful transition. So lastly is our follow-up with the patient after their first appointment. So we typically check in a few times after the appointment, once within a week or two of their first visit, and that's just to get a sense of the patient's overall reaction and to see how they felt about how their first appointment went. And a lot of them will have great experiences, which we love and is awesome, but many patients will still express that Shade Tree is their home. So that can be a little bit of a challenging component, as we never want to give a patient the impression that we don't want to serve them from a medical perspective. But we really use this time to emphasize the longitudinal component of our social work department. So we really strongly encourage patients to keep us, as they kind of describe it, in their family by coming back to see us anytime to talk to our social workers and keep us up to date on things happening in their lives or any struggles that they might be going through. So we think that this accomplishes two things here. One, it helps both our team and the patient feel a lot more comfortable with the transition. And two, it kind of gives patients, it gives us confidence that the patients will continue to have their social needs addressed and discussed, so that we can facilitate either helping them within our clinic, within social work, or, we can reach out to their new provider just to make them aware so that they can facilitate the best resources to their new patient. And finally, we'll typically call them after a few months just to make sure that, before their second follow-up appointment with their new provider, that any remaining concerns or questions have been addressed, and that, just to confirm that they feel supported. So I know that was a lot, and I hope that that's kind of been summed up in a digestible way. So now I'm going to hand it off to Shannon, our licensed social worker, and she'll talk to you about individual cases to give you guys examples of how this has worked.
Thank you, Michelle. So throughout this process, we have successfully transitioned over 100 patients, which has allowed new patients to be seen and treated at the Shade Tree Clinic. So this process is vital. And throughout this process, it is ongoing education for our staff, our providers, and of course our patients about the differences between Medicare and Medicaid. Many are confused about when they can apply, if they're even eligible, and what benefits they might have with their insurance. As for Medicare, many of you know that Part A and B and D is vital to be able to be covered for all of the services, where Part A covers your hospital insurance and inpatient care, and Part B is your medical insurance for physician services and outpatient care, and Part D is for the prescription drug. So we're going to briefly discuss 3 different patients that we have been able to transition from our free clinic to outside providers. The first one is a 59-year-old African-American female who is dual eligible for both Medicare and Medicaid. We have seen her since 2009 at the clinic for her complex medical needs. She benefited greatly from working with social work and legal aid during her periods of homelessness and received assistance in counseling and help with her lengthy disability application. In 2016, she was finally approved for SSI and became eligible for both Medicare and Medicaid. So if a patient has both Medicare and Medicaid, most of their health costs are likely covered, and they're referred to as dual eligible. She benefited also from this Qualified Medicare Beneficiary Program, which is called QMB for short, which helps pay premiums, deductibles, and co-insurance. It's for both Parts A and B. So now that she has both Medicare and Medicaid, she was easy to transition to Vanderbilt adult primary care at the main hospital, and she understands that she is always welcome to come back to clinic should she have further social or legal needs, or should she have questions about insurance. Next is a 61-year-old male who is a Medicare recipient. He also has extensive behavioral, social, and medical needs. He was treated at the Shade Tree Clinic for several years, and legal aid was finally able to assist him with his SSDI application, and he makes less than $1,000. So normally a patient qualifies for Medicare when they turn 65 or older, is a U.S. citizen, or has been a permanent legal resident for 5 continuous years. In this case, the patient became disabled for more than 24 months, and then he was qualified for Medicare and received Parts A and B, and we encouraged him to also apply for Part D assistance through our Tennessee SHIP program, which is the State Health Insurance Assistance Program, and also by calling 1-800-MEDICARE. After he was able to receive Parts A, B, and D, and we were able to make sure that he has all the parts, then we were able to refer him over to Vanderbilt for the adult primary care. Many of our patients are extremely worried about how they're going to afford their premiums along with their prescription costs, and that's why making sure that they apply for any subsidies or help that is available, we help them apply and secure this before they transition. Finally, we have a patient who qualified for Medicaid, which is our TennCare program in this state. And as you know, the states vary with their eligibility categories. But in Tennessee, TennCare is the state's Medicaid program, and it provides health care to low-income pregnant women, parents, or caretakers of a minor child or children, or individuals who are elderly or have a disability. But to get Medicaid, you must meet these income and resource limits. So this patient was a 43-year-old woman who immigrated from Bangladesh and has 2 young children that were both born in the States. She had received her green card and eventually became a U.S. citizen, and then was able to apply and receive TennCare. And after years of trying to get her to transition to a TennCare provider, we have been able to make her an appointment at a local FQHC, a federally qualified healthcare center, which is less than 1 mile from her home. We have continually had to educate her on the benefits of her TennCare insurance and reassure her that her prescription drug costs will be minimal due to the $4 formulary and the prescriptions that TennCare will provide. And she does have an appointment this month with a new provider.
Okay, so in addition to these successes, there are also stories of patients who were less successful. So as you've alluded to, there are many barriers to transitioning patients. We wanted to discuss these a little more in depth. The first is that patients can be extremely difficult to contact. This can be due to a variety of reasons, from odd working hours to running out of minutes on their phone and frequently changing their phone numbers. This makes it really difficult to get in touch with follow-up questions about their insurance coverage, as well as communicating about their transition. A second major barrier is the dependence of our long-term patients. As Michelle said, many of our patients refer to Shade Tree as home. So even in addition to this emotional attachment, many of our patients are reliant upon receiving free care and having people that can help advocate for them and even schedule specialty appointments outside of clinic when needed. It can be really jarring for these patients to have to assume more responsibility over their medical care and assume more of the financial impact of this care directly. With respect to this, we always do encourage patients to return to clinic to have us help address their social work needs. We've had patients that have returned for help with applications for utilities assistance, or once they turn 65, for explanations of the Medicare process. So this both helps with the emotional impact and can help us offset some of that increased financial responsibility. The final major challenge that we face as a student-run free clinic is annual staff turnover. So the majority of staff members, especially in the social work department, are first-year students. As they progress into their clerkship year, they don't have the time to devote to a full staff position anymore. So this requires that we train new staff each year. And this turnover is really not limited to social work. It happens in almost every single one of our departments, in addition to our clinical volunteers, as students move forward in their medical education. And so this presents a unique challenge in that there is need for retraining. In addition, even for our clinical students and some of those other ways that we're able to train outside of the department, adjusting to a new role within clinic and assuming more clinical responsibility can be overwhelming for students, and especially due to the medical complexity of some of our patients that can put things like screening for insurance on the back burner. So it is very important to educate in order to transition the transitions team itself. So at the beginning of each year, the entire social work staff is educated on the basics of the various insurance programs. This ensures that the staff social workers are effectively able to screen for insurance and to answer any questions that patients may have. Each subdepartment leader meets with the incoming staff social worker who will be assuming their role in order to pass along any knowledge they may have gained throughout their stay and help train the incoming department leader. This happens with transitions. And in addition to this, there is a combined transition meeting with the old and the new team. This provides the new team the opportunity to see how a transitions meeting runs, as well as prepare and present one or two patients themselves. We have found this really eases the transition, especially because the staff turnover is a particular challenge for transitions, as the enrollment deadlines for many of the programs happen early in the academic year. Finally, I myself served as a staff social worker who oversaw the transitions department, and there's definite benefits of having leadership that already knows the process. However, when this is not possible, Shannon, as well as our medical directors, have a lot of institutional knowledge that keeps this process running smoothly despite this frequent turnover. So no program is perfect, and ours certainly is not. So we are constantly trying to improve. So the main thing that we focus on is improving staff and student education. Every clinic starts with a staff huddle, and we've really tried to emphasize screening for insurance in these huddles so that everyone involved in the clinic knows that this is something we need to be aware of. In addition, we just transitioned medical records this fall, and so we're trying to use this new technology in order to screen more systematically in the medical record. We're also working on compiling lists of patients who will become eligible, whether that is because they're turning 65 or because they just got a new job that they would be eligible for insurance in a few months. Finally, we're working on creating a more systemized approach to follow-up to ensure that we're documenting this follow-up appropriately and that each patient is getting the support that they need to have the most successful transition possible. So to conclude, we wanted to discuss what we think are the keys to having a successful transition program. The first and arguably most important is having a designated person or persons to help oversee this process. As you can see, it can be a long and complex process, so having someone who's truly an expert makes a really big difference in how successful you can be in transitioning patients. It is also important to fill in any gaps in knowledge, skills, or experience by building partnerships. We would encourage all of you to explore local community resources and try to build partnerships as we've been able to do with legal aid and our health navigator. It's also very important to have a systematic process of assessing patients for their insurance status. It is also critical that this includes their social needs. So we do this, as we mentioned, in a variety of ways, but an annual needs assessment is one of the biggest ways for us. It's also important that everyone who will be involved in any way in this transition process is provided some training and education, as our questions are often met with questions of patients. So it's important that everyone understand the basics in order to be able to answer these questions or refer appropriately to whoever may be managing the transitions process. A big challenge that we face, and something that we want everyone to be aware of, is how important it is to work to set patients' expectations of what this process will look like. It's really important to talk to them as early on as possible to try to allow them to plan for the assuming of more responsibility, especially financially. Finally, in addition, having an interprofessional meeting or communication about the process allows for the smoothest transition possible, so that providers are able to input their expertise as well. With time, providers are able to see what referrals are the most successful and thus can make more targeted referrals to outside community providers based on individual patient needs. It's important that there is as warm of a handoff as possible with the new providers so that patients feel cared for and can receive quality care even in their first appointment. Easing this process really does make a big difference in the patient experience of their first appointment. Finally, it's important to provide follow-up. Not every transition is successful, and so ensuring that they still feel cared for and don't feel abandoned in the process even when their first appointment was not successful, goes a really long way in maintaining that relationship and increasing your odds of success during their next transition. So we hope that our description of our transition process and some of these tips that we've passed along will be useful to you and your programming. And we will now open up the floor for any questions that you all may have. Thank you so much.
Wonderful. Thank you all for that wonderful presentation. And at this time, if you are a participant and have a question for any of our panelists, feel free to type in your questions on the question pane at the right side of your screen in the webinar control panel. I have a question from a participant asking what, if any, do you utilize a specific tool, a specific screening tool for your social determinant screenings?
So we have a homegrown screening tool based primarily on health leads. We did a seminar with them and refined that tool. And so it includes a wide range of determinants from food to insurance to legal needs to transportation. And so we approach patients with this. The goal is to do this screening annually with each patient. And we found that there are certain needs that may not have originally been on the screening tool that we've added with time. The other thing I'll say about our screening process is that it is an in-person process, and it is much more of a conversation. So really our screening tool with time has evolved into more or less a sheet of paper with a bunch of different pictures and categories. So we ask patients if there's any particular concerns they have, and then do have some questions we ask each time about things like transportation, insurance, and so that is primarily how we screen patients. I
just wanted to add that a lot of our patients are Spanish speaking, and some of them also are illiterate. And so we do have the images with it for those who are unable to read. And we also have a Spanish version that we take for our Spanish speaking patients to help with them.
Great, thank you. Another question we have from our participants is, are you guys tracking any metrics in like reduction around emergency department utilization with your patients?
So that is something that we have not been actively doing. There was a study done a year or two ago that looked at the effect of joining Shade Tree on overall hospitalization, which didn't find a significant difference unless patients were referred from BUMC. So we are not really directly tracking that information at this time.
Another question one of our participants had was, what's on average the number of hours per week that the students engaged with Shade Tree are working, and what's their average caseload?
So as Kelly described in the beginning of the talk, there are roughly 8 social work students who are first-year medical students or nursing students who kind of rotate through attending different Shade Tree clinic shifts. So we typically have appointments open on Tuesday evening, Saturday morning, and Saturday afternoon. So that allows for 3 different students to be there each week. So we are in Shade Tree working with as a social work volunteer probably 2 times a month, maybe more. And these shifts last roughly 4 to 5 hours, I would say. So that's kind of our time involvement. However, as we described, there are a lot of time commitments outside of your actual shift at Shade Tree just to follow up with patients on their needs or their questions. A lot of our patients, especially those who are looking to apply for insurance, that involves a lot of phone calls in terms of making sure they have the information that they need, making sure they've heard back about applications and that's what that status is. So I would say that involves probably a couple more hours each week in terms of just reaching out to patients and following up on any needs that were addressed. And then to get at the final point of the question, I think was the caseload. So that kind of depends on your shift, and it depends on how long each patient case takes. So sometimes patients come in and you go in to screen them for, an annual screening, and you uncover hours worth of discussion that needs to be had with a patient. So it might be that you only see 3 patients during that, 4 to 5 hour shift. But I would say on average, we probably each see 6 patients during each shift that we're at Shade Tree. And Thomas may have something to add.
Yeah, I'd like to add to some of what Michelle mentioned. So a lot of what Michelle's talking about is what we do as students actually working as the staff social workers. But we also mentioned that the social work department is split into several different sub-departments, and we have 1 or 2 students overseeing each of those sub-departments. And those carry a lot of different time requirements. For example, people who are working on food security have a lot of work that they do in the clinic, and then following up with patients, making sure that they have access to food banks or have and are going to food banks and identifying any barriers they have to get there. Or on the other end of the extreme, you kind of have what Michelle and I do with the transitions, where most of our work is done over the phone, speaking with patients, preparing for the transitions meetings, and then following up after the transitions meetings. So she and I will spend quite a few hours leading up to the transitions meeting and then following up afterwards so that we can help transition people immediately after. And addition with that caseload, with those meetings, we tend to present probably around 7 to 10 patients, I'd say, each time we do one of these meetings. And we try to split those evenly between the 2 of us on follow-up. So we'll have roughly 4 to 5 patients. Some of these will go fairly easily when we transition them, and some will be significantly longer time investments. And these tend to be our more complicated patients. So this is not a very good answer to your question, but it really does vary on what roles the students have within the social work department, and also what your relationship is with the specific patients on your panel.
Great, thank you. Another question that one of our participants had, and Thomas, you spoke to this just in your last answer about connecting those patients with food banks, with other community organizations to help them address some of the basic needs that are being unmet currently. So can any of you speak to how you identified or built those relationships with local community partners that you're referring your patients to?
Sure. I think it's vital that we develop and keep these relationships with our community partners, whether we refer patients once a year or just continually. So we have developed a strong partnership with the Legal Aid Society of Middle Tennessee, and one of their staff attorneys comes every other week. We have a pro bono immigration attorney who comes every other week. Both of them are very dedicated to serve and volunteer our patients. So it is more of an informal relationship, but we both see, and our medical director completely values what our legal aid and the attorney brings and provides to our staff. We have developed a strong relationship with Family and Children's Services through their healthcare navigator. She actually sought us out. There are federal grants out there for the navigators to assist patients with applying and securing insurance. So she reached out to us, and she comes to our clinic once a month. We have more informal partnerships with the Salvation Army. I attend monthly meetings over there. We refer families to just various local community resources within the city. So it's not just merely a number. It is usually to a program director or somebody that's actually working at NeedLink or what other agency that we're talking about. So hang on.
One more thing to add, I think our substructure within the department of having the various sub-departments is really helpful for this, and that there is someone who is in charge of looking out for additional community resources, and they can then help build partnerships over years as well. So we recently have built a partnership with Interfaith Dental, and a lot of that was driven by last year's dental specialists into this year. And so having that substructure allows for a lot of partnership building that we have found hugely beneficial.
Great. Another question we had from a participant was wondering if the cost of the free medications that you guys provide comes out of your the budget that you listed in the presentation. If it all fit in there.
It does. So one thing to say, our patient assistance program is huge. So when we have patients that need expensive drugs, we have someone in clinic every single clinic session whose job it is to try to work with those patients to get them signed up for the programs, get the documentation in. So that is a big way that we offset a lot of our costs. One thing I will say that is not included in that budget number, Vanderbilt, as kind of their donation to the clinic, does run our labs for free. So that is definitely slightly depressed. That number would be higher once those costs are included. But that cost does include medication costs. But because we are Shannon is the only paid employee, and that's just part of her. It's a part-time position for her, and so that allows us to save a lot as well on our budget.
Great, thank you. And I know we're getting close to the top of the hour here, but I'd love to ask one final question for all of you is, when looking at clinics, what unique advantage do you guys have at Shade Tree by being a student-run and led clinic?
So I think one of the things that first comes to mind with that is just that, one of the things that med students have a lot more of than most other providers is time. And so we're, as students, able to dedicate a lot to these patients in terms of being present in clinic, multiple times per month, following up with them after clinic each time. So I think that is one of the really strong advantages to having a student-run clinic. I also think that it's a great way for students to develop leadership skills. And a lot of us are really motivated to be involved in caring for underserved populations, as that is something that has, inspired a lot of us to go into a profession like medicine. So I think that because of the motivations, our flexibility in schedule and kind of, our lifestyles outside of class, that this really allows us to give a lot more commitment to our patients, which I think really allows us to spend adequate time and give them adequate resources in each session.
I'd like to add on to that, not necessarily as something that, helps us with our patients as much as something that makes Shade Tree unique, is that it kind of serves a dual role. One is a social mission to serve those who don't have anywhere else to go, but also it serves a very educational role where it actually spends a lot of time training, the next generation of physicians with social determinants of health and how to care for their patients directly. And so we have first-year students all the way through fourth-year students who are filling different roles within the care team, and helps people just get a very good, hands-on view on how to actually care for patients and how to care for patients who do have these social determinants.
So one last thing I'd add is because of that educational mission, our relationship with Vanderbilt is huge. We are able to get patients inpatient care when they need it. That's written off as charity care. We're able to get patients to see specialists, as well as we're able to bring specialists to clinic. So we can bring in a cardiologist one night a month. We have a neurology, ophthalmology, orthopedics, sorry. We have a variety of specialty clinics that actually are able to happen in clinic due to our relationship with Vanderbilt. So I do think that is a unique advantage that we have.
Wonderful. Well, I just want to say once again, thank you so much to all of our presenters for this very informative webinar today. Thank you to all of our participants for joining us and for being very understanding with the technical difficulties at the beginning of the hour. But I just want to say thank you again, and I hope you all have a wonderful rest of your day. This concludes the webinar.
Thank you. Don't hesitate to reach out with any additional questions.